Good evening. It's another meeting today, but this time we will have a session on acute heart failure. Basically, hopefully, it will be a fruitful session for all of you because we'd like to make it as a practical approach to acute heart failure. I would like first to thank the Lebanese Society of Cardiology for their continuous support. And for this session, I would like to thank Merck for their generous grant. Also, I would like to thank you, all audience and participants, for having the time now to be with us. And hopefully, it will be a beneficial session for all of you. Also, at this time, it is my pleasure to have two not only colleagues but good friends and close friends of mine, Professor Wilfried Mollens from Belgium and Professor Firas Badr from Cleveland Clinic Abu Dhabi, who will share with me the session. And both of them, they are experts in the field of heart failure and in acute heart failure too. I will try first to start with the case presentation, and after that, we'll start with the first presentation about the pathophysiology of heart failure and the classification of the pathophysiology of acute heart failure and its classification. Then we'll go to the second lecture about management and especially decongestive strategy. And the third session will be about what can be done and what should be avoided in acute heart failure, and what are some concepts in acute heart failure. And then we'll leave the floor for discussion. So I will share my screen now. So I present to you now just a case presentation, after which we'll raise some questions that will be answered by our panelists. So this is a case that you all may encounter in the emergency room or in the chronic care unit. A 59-year-old male with ischemic cardiomyopathy post bypass surgery and multiple angioplasties before. His latest ejection fraction was 25 to 30%. And a couple of years ago, a CRTD device was implanted. And over the last 9 months, he was admitted once with acute heart failure decompensation. He has multiple comorbidities: hypertensive, dyslipidemic, hyperuricemic, chronic kidney disease with the creatinine of 1.5 baseline and GFR of 51. He is ex-smoker. He presented this time to the emergency room with progressive shortness of breath of 1 week duration. He reports compliance to medications, but he is not compliant to fluid and salt intake. No recent infection or fever reported, no non-steroidal intake, no chest pain. He is on a good regimen of medications. He's on secapentine of 200 twice daily, bisoprolol of 10 milligram per day, eplerenone of 50 per day, aspirin, atorvastatin, and furosemide of 40 milligram daily. So he started reporting dyspnea on exertion, which was progressive over the last 1 week. Last night, before his presentation, he had shortness of breath at rest, orthopneas, PNDs, and he's reporting to lower extremity edema that were increasing over the last 2 weeks. He reports weight gain, nocturnal cough over the last 2 days, abdominal distension. He has no palpitations and he denies any chest pain. In the emergency room, his blood pressure was elevated 160/85. His heart rate was sinus pacing at 91 beats per minute, saturation 87, so he was desaturating, in distress, wheezing. He has bilateral rails up to his mid-lungs. There was no significant murmurs on cardiac exam, soft abdomen, and +3 lower extremity edema bilaterally. So his work up in the emergency room, EKG sinus, no ischemic changes. His heart rate was around 80. Chest X-ray, bilateral diffuse congestion, mild bilateral pleural effusion, and no evidence of consolidation or any pneumonia or infection. Blood test, hemoglobin of 12.5, creatinine of 1.7. His baseline was 1.5. potassium of 5, sodium, a mild hyponatremia, a slightly positive troponin, and an elevated anti-pro-BNP. So in ER, he received 80 milligram IV push furosemide. He was given 2 milligram of morphine IV. CPAP, continuous pressure support, was applied. His respiratory distress improved, and he was transferred to CCU. In CCU, he was started on IV Lasix, continuous drip per protocol, with a urine output should be more than 100 milligram per hour, and accurate intake output. In the first 24 hours, the next day, blood pressure was 130/85, heart rate 74. His saturation at room air improved 94%. He had a 3 liters urine output for 24 hours with a balance of -2 liters. His sodium improved, potassium is okay. Creatinine bumped up to 2.1 from 1.7, knowing his baseline 1.5, with estimated GFR of 38, and his troponin was still stable. His exam, bilateral crackles were reduced, neck veins, they're still occurring and still have lower extremity edema. Chest X-ray, still a mild decrease in lung congestion, but it's still present. So this is one of the cases that we encounter in our practice as a cardiologist on emergency medicine. And there are several questions that should be asked and hopefully will be answered in the coming 3 lectures. First, was it enough to give IV diuretics in this profile of patients? Just IV diuretics is enough in this kind of, or this profile of acute heart failure patients? Second question, is it necessary to do an echo in the emergency room or in the first 24 hours during admission? My third question, is it necessary to insert a swan gas in this kind of patients or this profile of patients? Do you recommend coronary angiography in this patient with this mildly elevated troponin? Do we have to stop beta blockers in this kind of patients? Do we have to stop ARNI and MRAs because his creatinine bumped up to 2.1? Was the diuresis adequate? Is there any other method to assess adequate diuresis? With this elevation in the creatinine, what is next? Stop diuretics? Stop, hold ARNIs and MRAs, or give IV fluids, which can be done by some physicians. In case patient was on SGLT2 inhibitors, because this is one of the treatments for chronic heart failure patients nowadays, do we have to continue or hold this medication with this acute stress? A last couple of questions. In case the patient has ascites, is diuresis enough or we have to perform a peritoneal tap? And in case his blood pressure was not 160, 100/70, does that differ in the management? So I will end here my clinical case, and hopefully in the coming 3 presentations, this presentation will help us direct the management of this patient and answer most of these questions that were raised.